Good morning, everyone. Thank you for joining us this morning for our Healthy Ideas information session. If I have not met you before, my name is Angie Sullivan, and I'm an Older Americans Act consultant with the Greater Wisconsin Agency on Aging Resources, or GWAR, and I provide technical assistance to 70 counties and 11 tribes on evidence-based health promotion. And I wanted to do this morning's session. I've been with GWAR about 3.5 years, and over the past 3.5 years, I've noticed there's somewhat of a gap in evidence-based programming for the need and want of our aging units and ADRCs in terms of mental health and older adults. So I was able to attend the National Council on Aging in July, I believe this last summer, and I had the opportunity to attend a session on Healthy Ideas, which is a one-on-one evidence-based depression program for older adults. So I'm so excited to have Melissa Donegan with us this morning, and she's going to talk more about the program. But before we get started, I'm going to share our agenda for the day. Just bear with me on this Monday morning. I'm going to get it to a, okay, so you should all be able to see that. If not, put it in the chat, and I cannot see my chat feature anymore. So Pam, if you could let me know if they're having any trouble seeing anything. So our agenda for today, just our quick welcome, and then we'll have Melissa Donegan. She's the director of the Healthy Ideas National Training and Technical Assistance Center for the Elder Services of Merrimack Valley and North Shore, and that is in Massachusetts. We will have time after her presentation to do questions and answers, so please feel free to write in the chat, and I'll be revisiting those after her presentation. And then I want to have an open discussion at the end about the Healthy Ideas program and what implementation may look like in Wisconsin, and to gauge interest as well. So again, why I'm bringing this program to light here in Wisconsin. There's some recent statistics from Wisconsin on mental health and aging. So I want to just review a few of those, which you may or may not have seen. We do know that 20% of those 65 and older in Wisconsin, so approximately 200,000 people, experience some type of mental illness, and up to 4.8%, so almost 50,000, live with a serious mental illness. Obviously, that pandemic has caused isolation of older adults, which should be of concern. Also, we know mental illness can have negative effects on other chronic conditions, and older males have the second highest rate of suicide amongst all age groups. And kind of the bright spot here is if treated properly and early, 80% of those diagnosed with a mental illness will recover. And we're uniquely positioned with our infrastructure as the aging units and ADRCs throughout Wisconsin to be able to provide one-on-one education as well as group education. And when Melissa talks about the program, you can see it's currently being done and has been done in several different states. And then I am going to stop sharing my screen right now and make sure we don't have any questions in the chat before I turn it over to Melissa.
Didn't see.
Okay, so I'm going to turn it now over to Melissa Donegan, and she's going to talk about the Healthy Ideas program.
Thank you, Angie. Oh, I'm echoing. Is that just me? Okay, no, I'm fine now. Great. Morning, everyone. As Angie said, my name is Melissa Donegan, and I do work at a AAA in Northeast Massachusetts, Elder Services of the Merrimack Valley and North Shore. And there I am the Assistant Director of the Healthy Living Center of Excellence, which is the hub in Massachusetts for all things evidence-based programming. So even though we're a small state, we do have over 30 AAAs and lots of community-based organizations that implement evidence-based programming. So we're sort of the hub that oversees workforce development, training, implementation of programs. And so because we've had this infrastructure, Healthy Ideas was actually a little history on it. It was born between a partnership, Baylor College of Medicine and Care for Elders in Houston, which was a group of community-based organizations. So it was the very late 90s, early 2000s when the program was developed there, and then first implemented in 2002, and now we are in 26 states. So educational institutions are a great place to grow a program and do the research and get it evaluated, but not always the best place for it to live long term. So back in 2017, the folks at Baylor, who we had worked with for a very long time, not only through our work with Healthy Ideas, my organization was trained back in 2012, and I was involved at that time and became a regional trainer for them in the New England area. But just because of our work with our hub here in Massachusetts and being part of the evidence-based leadership collaborative, et cetera. So we were really, really fortunate and lucky that they asked us and chose us to be the new home. So that is how we became involved. So what is Healthy Ideas? So IDEAS, of course, social services, everything's an acronym. So IDEAS stands for Identifying Depression and Empowering Activities for Seniors. So this is a community-based depression program. It is a one-on-one program that works with older adults and adults with disabilities to detect, not diagnose. We're just detecting. There's no clinical qualifications for a Healthy Ideas coach. So we're detecting symptoms of depression and helping reduce those. The program is really meant to be embedded into some kind of ongoing case management service. So at my organization, we actually really now are working through a referral from our care managers and our nurses and our protective services folks that are out seeing clients, and we have interns. We have one-on-one coaches who are trained in many evidence-based programs in several one-on-one programs. So we're able to take referrals, and that works really, really well at my organization. We also have a few resident service coordinators that are trained. I've trained all different kinds of community-based organizations across the country, Adult Day Healths, but generally speaking, it is some kind of community-based organization with some kind of care management practice. And this is then another tool in the toolbox. Really, that's what it's meant to be, to help address depression. You know, I know at my organization, we saw many years ago that our care managers were asking, my gosh, it's over 400 questions, the initial assessment that we do with folks. And then there's certain pieces that are done, you know, throughout the year at reassessment visits. And the PHQ-2 is in there. So the patient health questionnaire, the two screening questions about depression. If someone answered yes to either of those, there was no stop in the assessment to address what, you know, how they had just answered. We're moving on to the next set of questions. And I feel like that so often happens. And this is just a really nice way for an organization to have an evidence-based black and white program to help address what we're seeing in our older adults. Another big piece of this program is improving the linkages between community-based organizations and healthcare professionals. So not only the PCPs that our older adults see, but also the behavioral health community as well. So we're really trying to break down those silos and improve partnerships. And we're also reaching frail, high-risk, diverse older adults. You know, we're really wanting to see folks who are usually underserved and not able to seek behavioral health treatment with the same ease that others might be able to. And I also will say right now, this program, obviously it was intended to be done one-on-one in person. However, it is approved to be done remotely right now. I know many organizations, mine included, have gone back to in-home visits with, the permission of the older adult. So we are currently doing this back in the home. However, we had great success the last 18 months doing it via telephone or video conferencing if somebody has that technology available to them. And we do still get referrals where the older adult feels more comfortable doing it over the phone, which is fine. So you are able to implement it either way, whatever is sort of going on in your organization right now. I have folks who have already been trained ask me, am I able to go out in the home? And I'm like, listen, I'm way up in Massachusetts. You do what your organization says is okay. There's no rules from Healthy Ideas about how it's done. We're just giving you the okay that it can be done remotely. So Healthy Ideas has 5 key program components. So when we either get a referral or when your staff are out visiting with their older adult and you figure out how this goes into the workflow they're already doing, the first place we start is a screening. So the patient health questionnaire, or the PHQ-9, or the GDS, which is the geriatric depression scale, and we use the short form, the 15 question form. Both of those are approved to be done with this program. So we ask those questions, and that is giving us a score. Those are both added up and scored, and we can sort of see where the older adult is at: low, moderate, high depression score. And then there's also a suicide screen that's part of that. So in some of the agency preparedness, I find most organizations do have some kind of suicide protocol in place. Of course, we're sending folks out into the community and dealing with things where suicidal ideation might come up. But that is a requirement for the program, is that your organization has some kind of protocol. What would happen, if the older adult did show that, they're positive for suicidal ideation on that. If that happens, we kind of pause right there just to deal and make sure we have a safety contract in place or whatnot. But generally speaking, we do the screening, and the screening then is sort of the stepping off point for the rest of the program. We're using how the older adult answered the screening, and we're going into the education portion. So we're saying, when we train, we say we use the tell me more approach. So we look back at the screening, one of the questions they scored positive on, and we say, you mentioned here you're not eating, anything, substantial every day. Tell me more about that. When did that happen? You say you're not sleeping well, or, you've really cut back on activities, which obviously a lot of our older adults have the last 18 months being at home. But we're using that to help educate them, and just to see where they are at. What did they even understand about depression? Have they ever been diagnosed before? Have they ever been to counseling or therapy? Have they ever taken medications? And through this, we're really trying to help reduce the stigma. The nice thing about Healthy Ideas is it is done one-on-one. So a lot of the other programs, the chronic disease self-management program, there's talk about difficult emotions. Somebody might not be willing to endorse their feelings in a group, but sometimes, when we're one-on-one with them and we can get, some rapport and, build some trust with them, they are more willing to endorse how they've been feeling for how long. And it's really also helping them see that how they're feeling is not a normal part of aging. So many, even doctors, of course, well, they can't drive anymore. Everyone's dying. They don't feel good. Of course they feel like that. And that's absolutely not true. And that's where this program can really come in and help. Really letting them know that there's help, there's medications, and, with this program, we can help. So referral and linkage is also one of the components. So this is not only trying to seek out if they are interested in any mental or behavioral health providers. You know, we've even had folks wanting to attend a support group for something going on in their life versus, you know, specific counseling. This can also be done, this program, with folks who are already in treatment, who are already taking medications. We really want to broadly screen people. At my organization, when we first started, we screened everyone. It's not who looks depressed or who we think is depressed. We really want to, you know, screen all people. We've now given all of our staff the PHQ-2 to administer, and that's where our referrals are generated from, and then we take it from there. Also, we use this program to help our clients better communicate with their PCP. There's some tools embedded in the program that we can help them prepare better for visits and just be more honest with their provider about how they're feeling and what support they might need. So behavioral activation is sort of the goal setting component. If you're familiar with evidence-based programming, you know that they all are pretty similar the way that they are structured and set up, and there's always some kind of goal setting. So we use behavioral activation, which is actually a method of treating depression. And it's, you know, it's embedded in social work and counseling. It's not anything that we made up for the program, but it is a nice structured way to help the older adults see the link between mood and activity. And that's something that we do try to show them throughout the whole program, is that when you do start feeling symptoms of depression over a prolonged period of time, you stop doing less. And then, of course, your pleasurable activities that are involved in your life, you're not going to be keeping up with those or even have the energy to do them. And it's just a really vicious cycle, because then you're just going to continue to feel worse and worse. So we show them that by adding meaningful, pleasurable activities back into their life, their mood is going to improve and their symptoms of depression are going to go down. The great thing about this program is no two clients are going to look the same. It's, again, very individualized. So we've been implementing this since 2012, and I can tell you, we have had people whose behavioral activation was to get out of bed and do personal hygiene and change their clothes a few times a week. That's how depressed they were. And then we had one woman who was a retired school teacher and wanted to tutor children after school, and everything in between. So it doesn't need to be anything that requires a skill change on the client's behalf. They don't need to, you know, learn how to oil paint or learn how to crochet. We're really asking them, what are some meaningful activities that, you know, you used to do, and what's coming in the way of you continuing on with those? Sometimes it is a physical limitation. You know, they're not physically able anymore to continue on, but we help them explore other things that they might be interested in. Again, sometimes this is something as simple as keeping up with, you know, household chores and bills, just so people feel a sense of accomplishment. It can be learning a new skill. It can be sitting quietly with a candle lit, you know, and just being with their own thoughts for 15 minutes a day. Just, it can be anything that is going to bring them, you know, pleasure and help improve their mood. Once they set their goal, we check in on them. That part was always telephonic. You know, we always tell people, if you're in, you know, a housing building and you happen to walk by their apartment and you want to check in, that's fine. But that, again, is individualized. You know, once a week, every 2 weeks. I have one of my staff has had a woman open now for almost a year, and they have a standing call every Monday morning, and she checks in. And sometimes it is specifically about the goals, and sometimes it's just a simple check-in. And I will talk in a minute about generally how long the program is. And then the program usually is, well, I'll just say it now, 3 to 6 months. It can be shorter. We've had folks who it was like a month and they were good. And then you hear, like I just said, we've had a client now for a year. And that, again, is all going to depend on the resources and the infrastructure within your own organization. It's generally about 3 to 6 months between, doing the screening and kind of working through the program, having them set their goal. And then it depends on what their goal is. It might be setting different goals every time you speak with them. Or for instance, back to our lady who wanted to be a tutor, it took quite a while, because think about how many steps we had to break that down into. Sometimes it was just she was going to make a phone call and then we were checking back in with her. And so we assess their progress, and at the end of the program, we re-administer the depression screening tool to hopefully see that score lowered. So yeah, the core intervention is done, again, over the course of 3 to 6 months, but could be shorter, could be longer. Again, usually implemented by a case manager or referred to a case manager. So again, we've had a lot of success with community health workers, interns, resident service coordinators. We're actually building a whole team of community outreach workers at my organization now, and they're all getting trained in healthy ideas. And so they take a lot of referrals, or when they're out doing whatever other work they're doing, they're always on the lookout for new folks. Again, it can be done face-to-face in a client's home or telephonic delivery. The training that I give provides everything that is needed for the program. There's a manual that comes along with the program, as well as some editable forms that folks can either edit to meet their needs, stick their logos on, etc. And then the ongoing supervision is provided within the own organization. So that's actually how I became trained in healthy ideas way back when I was a manager overseeing our case management staff. And so when I got trained, I was what was called the clinical coach. So we have somebody in a supervisory position within an organization that would provide just ongoing technical assistance sort of before and after the training, maybe doing booster trainings. I know we did office hours every time we trained a large group at my organization. We sort of did office hours right after, so folks could come and discuss, successes, challenges, ask questions, share what was going on with their caseload in terms of healthy ideas. And then it's worked out great, especially with interns, because they need, their supervision weekly anyway. And so that's a really nice opportunity for them. So I right now do all the trainings, all the technical assistance before and after. So I make sure everything is set up prior to the training, and then I'm available afterwards. For instance, I did a training last year for an organization in Sonoma, California, and I'm getting ready to do a booster training with them. Some of their staff just got pulled in other directions because of the pandemic and are feeling a little rusty. So they sent me a list of some things that they want me to review with them. So we're just going to do a quick 1.5-hour booster. So that's always available as well. So again, this program really was designed to help with depression. And of course, now we see it with the isolation, with the screening, really, they might be realizing that they have depression, for the first time, but really it's a great way to use their own responses, again, with the Tell Me More, to elicit information. There's a lot of motivational interviewing woven throughout this program. It was developed by social workers and psychologists, so it is very rooted in, counseling and social work. Again, education, showing them that how they're feeling is not a normal part of aging, and that it is a treatable medical condition. So through healthy ideas, and then maybe, looking into some behavioral health services. I know it's tough. My organization is in Northeast Massachusetts, and I know all of Massachusetts is really struggling now with waiting lists. I live in New Hampshire. I know it's the same here. There is a real lack of behavioral health providers right now. So this is also a nice program. We keep saying to our care managers, refer them to us for healthy ideas while they're on these wait lists, and let us see, how we can help. Again, the referral and linkage, being more open with their doctor, being prepared for those visits, and being honest about how they're feeling. And, exploring therapy if that's something that they've never done. And again, just always throughout the whole program, always linking mood and activity, whether we're, chatting with them during the education component, or whether it's a telephonic follow-up, again, always bringing in the mood and activity link, and just really showing them that even just adding the smallest thing into their life, it can really improve their mood and help decrease the symptoms. So, thinking if this is a good fit for your organization, getting buy-in from decision makers and the managers who would be supporting this work is really important. It does really seamlessly just kind of integrate into the work that AAAs and community-based organizations are already doing. Again, developing effective partnerships. We already had some really great partnerships with behavioral health providers, but this was a way to even increase that. And it is a big piece, again, to really bridge those gaps between clinical and community. Again, installing it, asking about depression, but what are we doing about it? So let's install these core components into what we're already doing. Is that something that your organization can do? And establishing a system for sort of documenting and collecting information about the program. There are no data forms that we require. Some programs have, a database that you enter things into. We don't have any sort of structured system like that with Healthy Ideas. So it's really up to an organization, how your staff are already documenting and what you're going to require from them after that. And then again, we'll train the staff, myself and Healthy Ideas, but you all would provide that ongoing sort of support and supervision as needed. So just thinking about how all of these things, how you could fit that in when you're making your decision. So the training is fully remote. I used to fly out to people, but now it is fully remote, done via Zoom. It's worked really well since the end of last June, 2020. I've done 17 online trainings across the country. So I've trained over 200 people. I've tweaked it here and there. I take the evaluation feedback very seriously, and it has helped sort of tweak things. So I sort of leave this up to organizations. There is a hybrid didactic course. It's about 2.5 hours, and it is self-paced. And that is something that staff can do prior to the training. And then I do a 1-day remote training. It can be split into 2 half days, which I definitely prefer. And I'm only an hour ahead of you all. Sometimes it gets tricky for folks on the West Coast with timing. 1 day is totally, we can do it, but I tend to lose people after lunch. People get very tired on Zoom, but it's a very interactive training. Every time I teach a component, we stop and we go into breakout rooms and we role play and do practice exercises. And in terms of the online didactic course, this is part of the technical assistance I do with the decision makers at the organization to sort of look at the group and see how much information they need. So I just trained a group of interns in Boston. And so they did the didactic course in addition to mine, because they're very green, they're still in school. The more information we could give them, the better. I also trained a group out of Ohio at a Catholic Charities, and the person with the least amount of seniority had been with the organization for 12 years. So these were very seasoned care managers. And, just through speaking to them, they really, the 1-day training was enough for them to feel confident, with the manual and all of that to go out and implement. So I sort of chat about that with folks and leave it up to the organization because it can be a little duplicative. But it's a really great course. So there are some organizational readiness tasks, getting manuals together. again, if folks are sort of needing a older adult 101 depression sort of update, you know, leaving that to the organization if any pre-training is necessary. Again, reviewing the agency policies. So having a suicide protocol, looking at workflow, looking at what department or who the people will be implementing this. So generally, anytime somebody reaches out to me in the course of 2 to 3 months, especially now that I'm not traveling, we can get something scheduled fairly quickly. And I did say to Angie that, you know, I know there's a lot of different organizations on here, and it doesn't need to be like $4,000 times however many there are of you. We can pool people together and fill however many trainings. So
Yeah, Melissa, I was just
a business girl, so
interject real quickly. I know when people saw 25 people, we don't have 25 people or $4,000. That is where, you know, I'm interjecting myself as GWAR and providing technical assistance. So what I'm doing is trying to gauge interest from folks. And then if there's enough interested, I would go ahead and coordinate this training, because I understand that resources are scarce in our aging units and ADRCs, and you're all very busy. So this is something that I would take on to coordinate, so you would not have to take that piece on as an organization. That's what we can discuss more on the Q&A. So don't let that scare you off from the program at all. So I'll let Melissa continue on.
Yeah, and also I know a lot of the ARPA funds coming down, you know, I believe it's in the B, looking at social isolation and healthy ideas. It is on the list of approved ACL evidence-based programming. So I have been talking to a lot of different states about how to use those ARPA funds to bring a healthy ideas training, and then utilize, you know, those dollars to pay for positions, or, you know, to pay for the program to be done. So, and this is also, you know, healthy ideas. At my organization, we run a lot of evidence-based programming. So it really is a nice way, you know, to pair with other programs that you might already be doing. You know, many organizations run more than one. So it is just like a nice, you know, addition to the menu or the cadre that you're doing. So again, reaching underserved populations. The one-on-one programs, you know, I love that they're tailored. Also, when you have a menu of programming, you can address their highest need first. We always tell folks when we are trying to generate referrals, don't worry about knowing every detail about every program or going to our website and looking at the program schedule. Just make a referral to us, and through motivational interviewing and just chatting with the person, we'll see what's going on with them. And then, you know, we'll put them into whatever program makes sense for them. But we love when, you know, folks will make a goal to then attend another program. So it's been really great, and having a variety of programming, you know, it's also attractive to funders or payors, you know, when you can check a couple of boxes: chronic disease, falls prevention, behavioral health, you know, things like that. And again, we do, you know, refer into chronic disease, matter of balance, et cetera, from the programming. So, all right, Angie, so those were the slides I chose from the presentation that you had gone to. So I can stop sharing so people have an opportunity to ask questions or.
Wonderful, thank you. So I'm going to turn to the chat. We do have a question. Melissa, is there an annual fee for a license?
No, very good question. So right now, there is no ongoing license. Once you get trained, you have access. We have a website, and there is it's called Adopting Agencies section. So you are given a password, and that everything is there. The original training has a lot of videos. I believe there are 9, and it's really nice because it's, you know, some didactic learning along with, there's 2 older adults. One she sort of plays like an easier older adult to move through the program. And then there's a gentleman that is really sort of in the pre-contemplation stage of the readiness to change and doesn't really see that there's anything going on. And they will do role playing, which is really nice. I've had people kind of work through the videos as like a booster training. I don't show them in the training unless someone really wants me to. But anyway, those are all there. And then the manuals. This program is available in Spanish, Chinese, Korean, and Russian if needed. So I can get it, not the training, but the participant materials. And the PHQ and the GDS are available in many different languages online as well. And so, yeah, you have, once you're trained, you have access to all of that.
And is there a cost for participant materials, or what will they need to participate in the program?
Yeah, no, there's nothing that they need. There's no like participant workbook. There are pieces, there are forms that go along with some of the different components. Those are all, the manual is split into two parts. One is the intervention manual. And then the second part of the manual is called tools and resources. The tools and resources is broken down by each component of the program and what you would need there. So really the only sort of paperwork needed is if they're going to do behavioral activation, there's a couple of different worksheets that helps, because when you're sitting with someone who's depressed and you're like, all right, let's set a goal, they're going to be like, okay, they have to sometimes fake it till they make it, and put action before motivation. So some of the worksheets that we do with them, we kind of look at what a typical day looks like for them. Then we talk about, well, what activities do you do? What aren't you doing? What's getting in the way of that? And then there's a pretty structured worksheet to set the goal. We always want it to be a SMART goal, so it's very specific, and we have them set a confidence level. So all of that's part of the manual. So at my organization, one of my staff makes up packets for everyone. So we just have a bunch of manila envelopes with everything that is needed. And I can even send, I have just like a Word document of every single form. And so our Healthy Ideas folks just always have a bunch of those. So then when they go to sit with somebody, they open the folder and there's everything they need from, we use the PHQ at my organization. So, the PHQ and et cetera. There's some other, forms available, but no, there's no participant workbook or CDs and things like some of the other programs. Yeah.
Great, thank you. And you mentioned the sample or suicide protocols. Then if an organization, ADRC or aging unit, they don't have a suicide protocol, is that something that you can assist with a template or steering them in the right direction?
Yep, I have examples of all of that. So normally when I meet with an organization about a training, we do a Zoom meeting. I talk about Healthy Ideas. I have a bunch of questions that I ask just to get to know the organization. And then I sort of go through what the readiness tasks are that they need to work on. And yes, I can share our suicide protocol. There's a couple of the pre-training, the one-on-one, Depression 101, with older adults. We have a couple of presentations that, are there. So I can share that so people aren't recreating the wheel. And the good thing, about this field is everyone's always willing to share. I'm sure if any of you are, involved with evidence-based programming, asking, just always ask. Somebody's always willing to share a document to be edited.
Great. I will pause. I do have a few more questions, but I'll pause and see if anyone listening has any questions on what this may look like in your organization, or maybe any roadblocks that are coming to mind. Feel free to just take yourself off mute and ask Melissa.
I put this in the chat, but how much time commitment is involved with this over the course of the first year and maybe the second year? And then who in an agency is the most likely person to be participating in this? Or is it
Mhm.
multiple people, like people who are doing running the Meals on Wheel program, or like myself in health promotion, or someone who's the benefits specialist or the caregiver specialist, or
Yeah, absolutely. So in terms of the time commitment, I mean, whoever's sort of organizing the training, which it sounds like it would probably be Angie, that is upfront, you know, a little bit of time putting everything together, but it would just be the training. And then, you know, everyone's caseload is a little different. So if somebody is going to be, you know, screening everyone on their caseload, you know, it's going to look different. Not every participant always wants to fully go through all the way either with behavioral activation. So sometimes you're just screening them and, you know, maybe doing some education or leaving them, you know, we came up with packets with some information on older adult depression. And, you know, sometimes they're not willing to have that conversation or do behavioral activation. But it is a nice way to, you know, open the door for future conversations. So it's hard to say if it's somebody, some of my staff just only have a caseload of evidence-based one-on-one program people. And then, you know, some other organizations, it's care managers who might have 10 of their clients in different stages of, you know, healthy ideas. So, but in terms of, I love that you said Meals on Wheels drivers, because right now we got our Meals on Wheels drivers are getting trained to be dementia friends. And then after that, they are going to be getting some new technology, and we're going to be actually putting the PHQ-2 into some of the questions that they're going to be asking people at least once a year through the Serve Tracker app. And so I love Meals on Wheels drivers. I actually am doing a pilot in Indiana with an organization who is using some Meals on Wheels drivers. So I love that. But yeah, I mean, you mentioned caregiver. We've actually done this program, you know, before with caregivers. The evidence base for this program is 60 and up, but we've utilized it with caregivers who were younger. You know, we're one of the community partners through an ACO project, and we actually have an Open Healthy Ideas client right now. Her 8-year-old son is a brittle diabetic, and she's actually doing healthy ideas. She's in her 30s. So we took that referral on. She can't get out to behavioral health appointments because of her caregiving duties. So, you know, there are a lot of opportunities to bring in other folks. But yeah, I mean, case managers, we've trained nurses, we've trained protective services staff, again, community health workers. It's awesome for interns because it's a quick training and they get that client interaction right away. I know that, you know, it makes for a really meaningful internship. There's an organization in Boston that I train. I've been training them once a year since 2013, and they bring in a group of interns every fall. So they're with them from September to May, and that's all they do is healthy ideas. So we can be pretty flexible. It was designed to be embedded into case management. But I know at our organization, the case management, it's like a revolving door. It's an entry-level job. My organization is huge, and we have a lot of specialty types of case management that people like to move into. So it was just getting sort of hard with the competing demands, and then of course with COVID. So for us, it's worked well to use them as a referral source. But I'll be training an organization like mine in 2 months in Massachusetts, and they're using case managers. So it really just depends on sort of your infrastructure and again, how you see this fitting into the workflow within your organization.
And I'll just add in there too, I know a lot of our, especially our rural aging units have limited staff. So you can use, you know, your 3D dollars for evidence-based programs with partner agencies. So if you have somebody in your community that you would like to partner, so you would not, you know, actually have to implement, you could also look to others in your community that maybe have the staff resources and work together if it makes sense. And every community is different, so it's really hard to say how that would look, but don't forget about, your partner organizations, and you don't have to do this all alone.
Mhm.
Any other questions that are coming to mind? I'm just checking the chat, so let me check, but
Yeah, actually, Lisa, I see that you're from a council on, is COA Council on Aging, or is that, yeah? So,
And as of January 1st, we'll be merging with our ADRC.
Okay.
So that brings in more staff, but
right.
we're
So
trying to
just
figure out who's
something,
doing
well,
what.
yeah, so I am pretty involved with the directors. My AAA covers 28 cities and towns, and we go out and do like office hours at the councils on aging. So they can make referrals to us and we will go visit older adults at their own home or do the program over the phone. But at a couple of our councils on aging, they give us space. Sometimes it's once a month, sometimes it's bi-monthly, and we sort of do office hours, and people will come in a confidential room, and we will screen the older adults and talk to them about depression. And some of them want to do the full program, and then we take the behavioral activation from there with them. We do go in and do a lot of like lunch and learns about healthy ideas. I'm actually going out to another council on aging next month to talk right before people get their grab and go lunch. We're going to hold them hostage for a few minutes, and I'm going to talk to them about healthy ideas. So yeah, there's all just sort of like, to play off what Angie was saying, even if staffing wise, it's hard for you, if there's somebody else here that's near you, that can partner up, that might work as well.
And I know we do have a lot of tribal representation on the call, and Neil had a question. Have you done any work with tribal communities?
Not specifically. So here on Cape Cod, we have the Mashpee Wampanoag, and we had partnered with them on the chronic disease program. And then that really was sort of hard getting off the ground. And then because of, staffing and an organization closing, we didn't in Massachusetts, and I have not trained anyone specifically working with tribal communities. But I do think I know, who folks will accept help from and trust is, something that's woven throughout all of these programs. So I do think, we know that evidence-based programs work really well when it's someone who looks like you and has your same life experience, running the program or talking to you. So I'd be interested to see how that would go.
Yeah, and I can talk to, with it being one-on-one, it is very individualized. So you do have the opportunity to bring in those cultural differences and make it really customized. And I found that has worked well with other evidence-based programs. So, getting that trusted person within your community is going to be key to the overall success. And I know one question that I had for you, Melissa, what types of qualities does it take to be successful within healthy ideas at an organization? What are some things that successful partners have really done that stand out?
Yeah, again, really having the buy-in, of the decision makers to just really fit this in and help sustain it. And just especially now with depression, social isolation, just being so rampant with the pandemic, and just the partnerships that folks have within their own communities. So again, not always just doing it on their own. Interns, again, have been great. They're free, and internships are very hard to find right now, just because everyone is strapped so thin and folks are just getting pulled in a million directions. But I know internships have worked really well. But just seeing how important addressing depression is among older adults. The successful organizations, they have champions within it that just kind of don't let it die, and are just really passionate about it. And I'm always willing, as long as it fits with Fidelity, to really sort of see how we can make it work for organizations. And, you know, I had somebody in Buffalo, New York, who I trained a couple of years ago, and with the pandemic, she had a local insurance company, you know, to the Western New York area say to her, we have some money, you need to figure out depression and social isolation in the community and what can you do? And she was already trained in healthy ideas, but they were adamant that they wanted to track and have data about social isolation. So we chatted and we piloted using the UCLA loneliness scale in addition to all of the healthy ideas, you know, screenings and paperwork and things like that. So, you know, just kind of rather than her saying like, oh no, this might not fit, you know, we figured it out. And, you know, they're doing that pilot and they're getting paid for participants and things like that. So, you know, just like any other evidence-based program. And that's sort of why I showed that slide about, you know, kind of adding this to your cadre. It's helped us, you know, we have some healthcare contracts here in Massachusetts, and we're able to say, okay, what do you want? Chronic disease, falls prevention, behavioral health, nutrition, caregiver. You know, we have these big 5 buckets, and we have capacity in all regions of our state, you know, to do this. So, you know, that usually helps as well.
Wonderful. And we did have a question, what funds could be utilized? You can use Title III-D dollars, and over the course of the next 3 years, you'll be getting more through the American Rescue Plan. Also, Melissa mentioned earlier, Title III-B as in boy. There is a language in there that you can use Title III-B funds for social isolation and loneliness activities. Also, don't forget about your local partners, and hopefully they could bring some funds in, but it could be, you know, adding hours to an existing staff person to implement the program. From GWAR's end, you know, I had mentioned earlier, we just want to gauge interest. It's such a gap area that we know we have a lack of access to mental health professionals. And a lot of times, you know, that home delivered meal driver may be the only person that they see. So we have a unique position at our aging units and ADRCs to be kind of a first, you know, detect and, you know, maybe a stopgap until they can get further, maybe into their mental health therapy appointment 6 months down the line. It seems like a wonderful opportunity, and it's definitely that area we need in Wisconsin to improve on. So on GWAR's end, I am willing, you know, if there's a group that are interested in being trained, working with Melissa, setting up training in Wisconsin and going through all the logistics, I can take that on. I do have in the very top of your chat, the very first item is a link. It's just a simple document that you sign up if you're interested in getting more information on setting up a training in Wisconsin and being kind of a first pilot group to see if we can get things going here in Wisconsin. So if you would fill that out, or if you don't want to fill out any forms, just send myself an email and I'll be keeping a list and then contacting those who are interested. We did have several people request the meeting be recorded. So I anticipate we'll have more interest as well. So I am really hoping that everyone is interested, and any feedback. I know we have like 4 minutes left, but I just want to open it up to folks quickly for any other questions, comments, concerns. You can always email me privately as well.
Angie?
Yes.
I just wanted to say from the State Office on Aging that we are very supportive of this program. And I thank Melissa for speaking to us today and Angie for bringing this to our attention. This is the silent killer among older adults. And we need to do everything we can to support older adults in their mental health. So thank you both for bringing this to our attention.
Thank you, Neil. I really appreciate that and the state's support in this initiative. Any other comments or questions? Oh, it looks like Pam has her, oh, she's clapping. I'm sorry. I thought that looked like a hand raise, but she's clapping.
I just have to say, I love your dog in the background.
I have had a few private messages about my dog.
Yeah, I had to do the mad dash to like find out what my dog was barking at like crazy earlier. So then I got disconnected. So sorry.
Yeah, well, it brings up a good point. Pets are definitely therapy, and there's a lot of research on that helping with mental health as well. So that's our mental health for the day, is Bella in the background. So it helps that she's 11 and she just went for a brief walk and she's tired. So thank you. Oh, and Neil's fish. So we've got my dog and Neil's fish. Well, if we don't have any other questions, again, feel free. I did put the link in the chat a couple times, but the meeting's being recorded, and I will send out the recording in the Guar Digest. I also will send it out to the Health Promotion and Aging Unit Director list. So if they missed the meeting, they'll have the recording and be able to do that. So over the next few weeks, I'll be capturing those counties that are interested in moving forward. Again, if you fill out the form, you're not vetted to that. If you change your mind, that's fine. I'm just trying to get an interest level to see if I should move forward in working with Melissa to get this in Wisconsin. And again, has been on the approved Title III list, but we haven't had any counties in Wisconsin participating yet. So I want to personally thank Melissa too for time out of her busy schedule. And I know she's got a lot going on at her house too. So I appreciate the time, Melissa, this morning on this Monday morning, and everyone for joining in. Thank you so much and have a good rest of your day.
Thank you, Andy. Thank you, everyone.
Thank you.